Hello, and welcome to today's education session webinar on the new reimbursement pathway in wound care for the MolecuLight-iX bacterial imaging procedure, featuring Leah Amir and Dr. Eric Lulov. Leah Amir is the Executive Director of the Institute for Quality Resource Management and the President of Vantage Links, located in St. Louis, Missouri. Dr. Eric Lulov is Chief Medical Officer of the West Boca Center for Wound Healing and has been a practicing wound clinician for more than 15 years and highly published in the field, located in Coconut Creek, Florida. And we're very excited to have them both with us today. This webinar is provided for general information purposes only and does not constitute legal or professional advice. And Dr. Lulov has the following disclosures as well. We'll pass this over now to Leah to get us started.
Thank you very much, Dr. Rennie. Very happy to have this opportunity to share the new reimbursement opportunities with the MolecuLight procedure. We're going to describe the new reimbursement codes. We're going to explain the clinical benefit related to the MolecuLight procedure, and then provide some billing tips associated with documentation and coding in place of service. And then again, in a Q&A, we're going to review the documentation required for appropriate billing. So what are these new codes? Effective July 1, 2020, we now have two Category 3 codes defining this new breakthrough technology that is defined as 059AT, which is non-contact real-time fluorescence wound imaging for bacterial presence, location, and load per session, first anatomic site, for example, a lower extremity, and code 0599T, which is for each additional anatomic site, for example, an upper extremity. These codes are to be listed together if there is a second anatomic site. It's important to note, while some people might be concerned that they might not get reimbursed on Category 3 codes, it is the only way new Category 1 codes come about. And in 2018 and beyond, Medicare paid for over 47% of Category 3 codes at the tune of over $230 million. So there's every reason to participate in this new coding process. What are Category 3 codes? They are to identify new technologies that lead to new procedures. In this particular case, these codes can be used to report the physician's work in the procedure to the patient's insurance company. And this is part of the typical process any provider would do to bill the work that they've just completed. Category 3 codes are used and will be monitored by the payers across the United States, as well as the American Medical Association, to identify how well this new procedure is being adopted in patient care settings. And it's to inform the medical insurers about the physician work and the necessary devices that are used during the procedure. And clearly, payment may be negotiated with each payer because it's a new Category 3 code. At this time, when the physician is doing the work, these codes can be billed from most all places of service. None of these have been excluded from any particular site of service at this point. And when you're billing for this particular new procedure, the fluorescence imaging procedure in a hospital outpatient setting, if you bill code 0598T on the claim form, both the physician will bill this as well as the hospital outpatient or other facility. For hospital outpatient, that code maps to APC 5722 with an assigned fee schedule payment. Here we're showing an example of the codes, and right now there is no certainty of payment from the physician office or physician facility payment that will be negotiated by the payer. And when the code is being billed, the physician will include the 0598T or the 0599T along with the amount charged. We do have, however, fee schedule payments for ambulatory payment classifications or ambulatory surgery centers. And Dr. Lulov is going to describe what this procedure is and how he does it.
Thank you, Leah. So when we talk about how to actually perform the procedure and what we're actually doing with this device, is we're literally looking at the load, location, and extent of the bacteria that are in the wounds that we're imaging. And what's really fascinating with this new technology is that it's a handheld, non-contact, non-infrastructure device. So it's not tied to the radiology department, it's not tied to the laboratory, the clinician and the wound nurse can be going around a hospital doing rounds. It can be used in the outpatient wound clinic from treatment room to treatment room, obviously cleaning the device in between. But for the most part, it's pretty much a portable imaging device. And the additional use of a dark drape, which is provided by the company, creates an optimal darkness for imaging in rooms that cannot be adjusted for environment lighting, such as a window that can't be completely blacked out. And because it's a portable device, you can use it on any wound in any location. So how does it actually work? Turn off the lights to use the dark drape, or in a darkened room that doesn't have a window. I'm very fortunate that my treatment rooms do not have windows, so I can just do this straight without the dark drape. So then the clinician will turn on the violet light. You'll position the device 8 to 12 centimeters from the wound. There will be a light indicator that will change from red to green when you're in the proper zone for imaging, and then you'll capture the image. At this point, you'll be able to see and document the fluorescence. The bacteria will appear red or cyan. You can see multiple areas of fluorescence as well. So at that point, also, you can do a static image with the device. So you will place the wound stickers that are provided that come with the MolecuLight device. Again, you'll position the imaging device 8 to 12 centimeters at a 90-degree angle to the wound, and you will get a static measurement that will measure surface area, and then you manually put in the depth measurement. This will allow you to get greater than 95% accuracy under the auto mapping feature, which will calculate out your wound edges in both length and width for you. Because we're able to determine location, load, and presence of the bacteria, the device will basically detect bacteria at loads greater than 10 to the fourth. And because there have been multiple clinical studies that have reviewed the technology, it's pretty consistent data that you'll be receiving from the device in making your clinical assessments on wounds. And you can see here in the image with a standard image, it doesn't look terrible, but you can see some friability in the peri-wound surface. But what you can't really tell is how badly inflamed and fluorescing there is bacteria within this wound that you cannot see with the naked eye. And that's where this device makes a difference in your clinical decision making. So when we consistently talk about how does this fit into the paradigm of our treatment plans for patients, so what it really looks at is you're able to early detect changes in the wound bed consistent with dynamic reciprocity of bacteria in wounds, and you're able to assess this in a much sooner process. You have the ability to target sample your culture swabs or your pathology studies. You can do better wound bed preparation prior to application or making the decision to apply a cellular tissue product or doing a skin graft. This is going to change your treatment selection process for dressings, whether you're going to use intact collagens versus hydrofibers, versus whether or not your negative pressure therapy is working appropriately. Are you doing adequate compression? And you're able to monitor and change your outcomes on a week-to-week basis, or as often as you are needing to frequently image these patients. You now have the ability to make on-the-spot care decisions based on additional information that you're going to be able to obtain from using the MolecuLight device. So as a clinician, the question then becomes, how do I bill? And Leah brushed on it earlier about the new codes to be used in both point of service, office, home, APC, and other facility places of code. So let's talk about this. So you can see here in representation of a case study with the use of the MolecuLight device. This was a 66-year-old diabetic male with a history of a transmetatarsal amputation and a rotational flap that was performed in 2019 in approximately October. At the time, I did not have the MolecuLight device, and I did not receive the MolecuLight device for use on this patient until 2020. But what you can see is I was able to do a linear measurement using the auto measurement feature. The depth was manually put in, but it auto-calculated his surface area at 36.34 centimeters. In the fluorescent imaging, you could see the red fluorescing bacteria both at the inferior and superior aspects of the wound, along with maroon coloring on the lateral aspect of the wound, which showed active bleeding. What this is showing me is information beyond what you're getting from a static image or the naked eye. And as a result, it prompted me to do further debridement and do better edge effect debridement on this patient, not only on this visit, but also in subsequent treatment visits. So in order to document the procedure properly, because it is a procedure, you want to have a very good description of what you're doing. And the key points you need to include is the anatomic site, the size of the wound, and the appearance of the wound. You want to document the clinical need for presence of infection and or pathogenic bacteria. You want to make sure that you list the name of the procedure like you would in any other surgical procedure. You want to say non-contact real-time fluorescent imaging for bacterial presence of X location. You want to report the results of the imaging procedure. You want to state that you might want to say, quote, red fluorescing bacteria was noted in the area of chief complaint. You want to include any medical decision making as a result of what you're seeing from the imaging. You may want to say, at this point, with no evidence of bacteria, the decision to proceed with application of the cellular tissue product will proceed as forward. And you also want to use that you stated using the dart drape if you are using the dart drape during your procedure. So as you can see here on the progression of this patient on the second slide image, so going from visit 2, which we have previously seen, and going to visit 3, that the amount of fluorescent bacteria was reduced at the superior aspect of the wound, but he had more highlighting red fluorescence on the inferior plantar and dorsal lateral aspects of the wound. And that just continuously indicates to the clinician that you have to do a better job not only in exudate management, but also in your debridement technique. But what you can see from week to week, just this demonstration of a reduction of almost 6 square centimeters in surface area. And this is partly because of identifying where there's bacteria and being able to remove and treat that bacteria on a week-to-week basis at point of care. If you do happen to have multiple wounds that your patient encounter, and you're going to be using the MolecuLight device to image multiple wounds and they're at different locations, there is a procedure in the billing process that we have utilized with these 2 new codes that went effective July 1st. For 2 wounds on the same anatomic location, say right lower extremity, you will bill the number of units with the first code 0598T with 2, 3, 4 units depending on how many wounds there are on that particular extremity or site. If you have an additional site, say the patient comes in and they had Mohs surgery on the left leg and they had Mohs surgery on the right leg, the second anatomic site, in this case the left, would be designated the 0599T. If you are practicing upper and lower extremity wound care and the patient came in with wounds, say on the right leg, the left leg, and the rear torso, you would then code 0598T for the right lower extremity with the number of wounds or units. Same thing with 0599T for the left extremity. And then you would code a second 0599T for the additional site for the torso. And here you can see in this additional information chart that these 2 category 3 codes may also be used in conjunction with additional service codes in your visit, say your surgical debridement of subcutaneous tissue, or if you choose to directly close a wound, making that determination that that wound is able to be closed secondarily with no fluorescent bacteria. And then you also want to include coding for the dart drape and the use of the durable medical equipment for the use of the MolecuLight device.
So for frequently asked questions, we've heard from those that are billing for this particular procedure. One would be, can I bill this in addition to debridement or other procedures during the same office visit? And the answer is absolutely. Always bill for the work that you do. In this case, we're showing a demonstration of 0598T, very similar to the case study that Dr. Lulov has just described. And during that fluorescence imaging session, it was identified that the patient was going to require some non-sharp debridement. In addition, we're recommending for reimbursement purposes and to educate the payers that you use code 13999 for durable medical equipment, and on that line you could identify that this is the non-contact real-time fluorescence imaging procedure. For A4649, you could include non-contact real-time imaging dark drape or just dark drape. If the wound is cleansed with non-sharp debridement and then imaged once again, you would use 0598T with units of 2. Even though you're in the same anatomic location, you have now essentially done the work 2 times. And it is also possible that the patient encounter may only be for imaging of bacteria-causing infection. Therefore, the 0598T code could be a standalone procedure. At this time, this code does not have any multiple procedure discounts associated. Do you bill per wound? When submitting a claim, include the units, the number of wounds per anatomic site, as Dr. Lulov has discussed earlier. If there is an additional anatomic site, use code 0599T. We are not summing the size of the wound. This is payment based more on anatomic site because of the recognized work to position the MolecuLight and the dark drape at each anatomic location. And how many times can I perform the procedure on the same patient? The application of the procedure is based on the clinician's medical judgment and understanding of the patient's underlying comorbidities. So as Dr. Lulov might have identified, some patients he might check every 2 to 4 days, others he might go once a week. If wounds with the bacterial infection that may need to be imaged more frequently, maybe biweekly, that is again based on the physician's judgment. And can this be used for the long-term care or home setting? As long as we're billing for the physician work, these codes have not in any way become part of consolidated billing. There is nothing to restrict the billing of these codes for physician work or their assigned clinician in any site of service at this point in time. They should be submitted on the physician bill, which would be a 1500 form, and the variance would be the place of service. And if the physician is using their own MolecuLight device and the dark drape, we recommend that they do bill for the device components, as again, we're educating the payers. And the APC code the APC 5722 cannot be used for long-term care or home care settings. Again, that is for hospital outpatient settings. How can I set up billing for these codes at my facility? Well, certainly if you're in a physician office setting, update the system that you're currently using for your billing. Most billing software should have updated on July 1, 2020 to include these Category 3 codes. If, however, you're working in a hospital outpatient setting or an ambulatory surgical center, please contact those individuals responsible for the billing in your facility. When they learn that there's new documentation coming across, such as non-contact fluorescence imaging of bacteria, typically people in the coding department are going to ask, well, what's happening? So MolecuLight has got documents that you can provide to them showing the codes. We also have ICD-10 codes as that might be required for the facility.
How do we handle denials? Well, we know that the denial is the ugly word in medicine, so how do you handle this? You want to do this as quickly as possible. You want to address it as soon as possible. So you want to make sure that you look at the payer's resubmission and appeal process. It's very important that you understand whether you're dealing with a commercial payer or you're dealing with a Medicare contractor, what exactly is the appeal process and how many days do I have? You want to make sure that you follow up with the appeal to make sure it got processed. That's the most important step. The first step is to make sure you get it in. The second step is to make sure that they actually got it. And then you want to resubmit the claim with all medical documentation from the patient encounter, which includes documentation of your procedure of the MolecuLight that's being performed. And you want to make sure that you've included everything that's medically pertinent to receiving reimbursement for use of the MolecuLight. And you really want to make sure that your medical necessity is in there, the findings of the wound, what you did, and what is the patient disposition and the outcome of that treatment visit. So you're showing a pattern of concise, consistent medical care. And like I mentioned before, MolecuLight also offers a reimbursement hotline for assistance. Again, these codes were published in the June 2020 edition of Today's Wound Clinic with a very well-written article by Leah. And again, you can go to us.moleculight.com/reimbursement for more information. And you can certainly have more information detailed to you as necessary. Again, thank you very much for attending this webinar. And at this point, we'll entertain questions.
So we do have some questions. The first one is, are these codes E&M or evaluation and management only for physicians, or are these codes open for wound care to other specialties, for example, physiotherapy? Leah, could you handle that question?
Certainly. These codes in particular are for the procedure and physician work associated with conducting the MolecuLight fluorescence imaging of bacteria. To the extent that there is a person working under the guidance of a physician and is appropriately credentialed to do the procedure, then they could do it. But this is beyond evaluation and management. It's an actual procedure where the work has to be done and then the image is captured, and then there's an analytical phase where the doctor makes decisions based upon the fluorescent image.
Okay, we do have a couple of questions about the long-term setting, long-term care setting. Someone writes that they do not have a physician in-house, but they have two who come for rounds each week. Would the facility still be able to bill for the procedure if a WOCN or RN nurse would be the one using the MolecuLight? Leah, could you comment on the long-term care setting?
Sure. Certainly the regulatory Medicare guidelines for what can be billed in a long-term care setting versus a skilled nursing facility will prevail. However, these codes are not in any way part of consolidated billing. So right now, when a physician is rounding on those patients, if they were to do this procedure, it would likely be billed just as any other debridement code, where the physician would put the place of service on their 1500 form and then indicate the 0598T and the 0599T as Dr. Lulov has described. If there are specific scenarios where the skilled nursing facility would want to do incremental billing, we can look into that because we are in very active conversation with the payers across the United States. However, likely it's best to bill as you would other procedures that are not part of any consolidated billing for a skilled nursing facility, and certainly those are accepted for long-term care as well when the doctor rounds on patients.
Another question about the miscellaneous supply code for A4649 is whether this code would work with the MolecuLight sterile sleeve device cover for use in the operating theater. Leah, can you comment on use of that code?
Well, okay. I guess when you use the concept of an operating theater, clearly all our billing is based upon the place of service. So if you're using the A4649 for the dark drape, which is used per wound, then the E-shield for the sterile device cover could be billed, it's possible, using the A4649 and including the units. As Dr. Lulov said, we're now in a training phase with the payers, so there'll be a give and take on that as to what might be paid. But at this point in time, there's no reason that we could not bill the E-shield sterile device cover.
Okay. And another question here, this one's about hospital-owned wound clinics. They want to know if in that setting, in a hospital-owned wound clinic, can the hospital bill Part A Medicare for this procedure?
Okay, so it's a hospital-owned wound clinic. If it's a hospital-owned wound clinic, and if it's on campus and they're billing in that it's an outpatient procedure, the patient wasn't admitted, then that's absolutely something they could bill. They would bill the 0598T, and that's what would map to the APC 5722.
Who would like to address whether you can use modifiers with the Category 3 codes?
Dr. Lulov, you or I would?
Yeah, I can take that one.
Okay.
Not a problem. So certainly you can use modifiers for these Category 3 codes. It is not uncommon, because I do mostly lower extremity wound care, that I will use the left and right modifiers and attach those to these Category 3 codes when I submit my claims. I tend to avoid the T1 through T9 for the toes. It's just I use the extremity codes to define, because the majority of my patients have multiple wounds on the extremity, so it wouldn't make any sense for me to bill a T1, T2 code for a left foot when I've got 2 wounds on the left leg and 2 on the foot. I would just submit 4 units with the 0598T with a left, for example.
Thank you. Thank you. And Leah, could you comment on the multiple reduction status indicator of T assigned in OPPS?
Certainly. It's not at all unusual that in the hospital outpatient setting for reimbursement, that when Medicare assigns a CPT to an APC, there are always status indicators associated. In this case, the status indicator T indicates that the highest, if this procedure is billed with other codes that are also of T status, that the highest paying T status code will be paid at 100% and the subsequent would be paid at 50%. So it also identifies that this particular procedure can certainly be a standalone procedure. We've learned that through the clinical trials as well as the physicians that are currently using it. And, you can read published studies or ask others, but frequently the imaging is done, the identification of the region and concentration of the bacteria 10 to the 4 or greater identified. And at that point in time, sometimes the physician completes the procedure by cleansing the wound. So that could be, it's definitely intended to be a standalone procedure if that is sufficient at that point in time.
Thank you. And a question for Dr. Lulov, who's been billing to these codes. There's multiple questions coming in asking how much the reimbursement is or what these codes have been paying in the field. Can you answer that, please, Dr. Lulov?
Sure. So your reimbursement is going to be based on how much you bill. The APC has a national fee schedule of $253 in the outpatient department setting. On the outpatient physician side, I have seen varying amounts of reimbursement, which we are still working with multiple payers because they're still getting used to these new codes that they haven't kind of really figured out the RVU assignment entirely yet for this procedure, even though we have submitted multiple levels of documentation for them for review. What I can say is that United Healthcare is reimbursing for this on the commercial side and on the Medicare Advantage side. Aetna is reimbursing both on the commercial and the Medicare Advantage side. What seems to be slow, which is really what the biggest surprise for both Lee and I when we have been discussing reimbursement has been on the Medicare side, has been a little slow on the uptake on what exact RVU value they are choosing to assign this procedure to. And Leah, I don't know if you want to help comment on this because I don't think I can go any further without divulging information that probably should not be divulged on a webinar.
Right, so what he's referencing is that these are claims being submitted with place of service 11. And certainly we've done a lot of communication with the payers across the United States, and there is the transmittal that identified the code to be paid in an outpatient setting or ambulatory surgical setting. But what we are working through right now is making certain that the payers, that the MACs in particular, are seeing the Category 3 code and finding a way to make payment. We realize these are carrier priced, but the evidence is pretty astounding relative to the quantity of clinical trials and the quality of the outcomes. So we have a lot of payers engaged in conversation, and meaning those are the MACs, as we said. Oddly, as Dr. Lulov referred, it's strange that you see the commercial payers paying before the MACs do. I know it happens from time to time, but this was a little surprising to us, and we certainly hope to maintain that trend.
And I do see some questions coming in about either where to go to purchase a device or the cost of the device. And of course, that'll vary based on jurisdiction. So for those questions, I'm going to refer people off to MolecuLight. The website is listed on the slide there at www.MolecuLight.com, or they can go to info@MolecuLight.com for additional information on that. And then another question for Leah and Dr. Lulov, is this payable under OPPS? So we seem to want a little clarification on that from the audience.
Yes, this is intentionally paid for right now under OPPS. And what we mean by that is the code 059AT has been given an assignment to a payable ambulatory payment classification, 5722. There is a possibility that a regional MAC could find a reason to not pay for it, but generally in the conversations we've had thus far, it appears as if, since this has got a fee schedule assignment, and with the data that's been available, it appears as if payment will be made. So hospital outpatient or OPPS payment came out in a transmittal, which we can share with all of you, indicating that this is to be paid. As I said, it's 0598T assigned to an APC with a reimbursement amount. Payers can always do whatever they choose in the end, but we have every reason to believe that the process is in play for payment to occur.
Okay, thank you, Leah. And I think we're nearing the end of our question period. Let's just see if we can answer one more. There's been some requests for clarification on what's been said in an earlier question from Dr. Lulov about receiving payment from commercial payers. So, Dr. Lulov, can you confirm whether or not you have been paid by commercial payers?
I have been paid by the commercial payers, specifically United Healthcare and Aetna and Cigna.
Okay. And another question has just snuck in. Is this reimbursable through the VA?
The answer is yes. The VA system has very much adopted the coding and some of the coverage policies that are currently active with Medicare. VA is, of course, a separate system, so I can't say for certainty, but you have every opportunity to bill if you're in a VA setting, and then if there's any denials, we can work through that process.
And let's cap it on. We have a question here that's very timely. It seems to be about telehealth, which of course is on everyone's mind right now. And the question is, does a hospital need to own the device, or can a third party perform the imaging, relay the information to the physician for their analysis, and then be billed? Leah, do you have any comments on that?
Sure. You know, what we're doing right now, because this is a new procedure with Category 3 codes, and at least we have the recognition from CMS for assignment to a paying APC, we're considering this an education phase. So right now, we know that there's nothing that would prohibit that kind of a scenario given the current regulations, because we are working with new codes. So for some particular hospitals and their physicians and then their associated home health organizations, we've worked out for them with communication at their regional level with their MACs what would be an appropriate scenario. So right now we do have some cases where the physician is observing the image that has been taken by a healthcare worker assigned and credentialed to do this procedure in a home healthcare setting. And then we're right now in the early phases of that billing and working with the payers. As I say, it's really right now an education phase.
Okay. Well, thank you so much for the excellent questions from the audience, and a special thank you to Leah and to Dr. Lulov for presenting this information and speaking so thoroughly in the question period. We greatly appreciate your time. And we hope everyone has a good day. We refer you off to www.MolecuLight.com for any additional questions. And thank you very much.
Thank you. It's our pleasure.
Thank you very much for having us.